second appearance on our Wednesday webinar series. His previous presentation in April of 2008 was on Tourette syndrome in early childhood and adolescence and is available for free download on our website. Dr. Brown is Associate Professor of Neurology and Pediatrics at the University of Pennsylvania School of Medicine and Children's Hospital of Philadelphia. He is Director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children whose complex learning and behavioral issues have neurobiological basis. This population includes children with Tourette syndrome, high-functioning autism, complex ADHD, epilepsy, genetic syndromes, and other neurological disorders. His current research interests include clinical drug trials in Tourette syndrome and ADHD. Dr. Brown is a senior clinician in the Pediatric Regional Epilepsy Program at Children's Hospital of Philadelphia, where he is principal investigator on numerous clinical drug trials in pediatric epilepsy. In addition to his wide interest in behavior in epilepsy, he is board certified in sleep medicine. He has numerous professional affiliations in the child neurology and epilepsy fields, including he is currently serving as president of the Child Neurology Foundation. He is also a member of the American Academy of Pediatrics Subcommittee on ADHD, which recently published new guidelines for diagnosis and treatment of ADHD. Dr. Brown, welcome and thank you for joining us tonight. We look forward to learning more about sleep and its impact on children both with and without developmental disabilities. So without further introduction, I now turn tonight's presentation over to you.
Thank you very much, Marty, and welcome everybody. I appreciate that kind introduction, and I'm not sure how to deal with the fact that you don't endorse my accuracy or usefulness, but I'll do the best I can. For those of you who were listening to National Public Radio this morning, I was particularly interested because they were talking about sleep as a national health priority. 30 million Americans who are suffering from inadequate sleep, billions of dollars wasted in terms of productivity. It really is a problem that extends throughout the lifespan, but I'm going to talk about sleep in children and talk about how it affects those with developmental disabilities and very little, but a little, about children with Tourette syndrome. Let's see if I can figure out how to run the slides. Here you go. How important is sleep? To me, it's incredibly important. It certainly has scientific interest. For those of us who are interested in children, it reflects the evolution of brain development. Problems in sleep have significant behavioral consequences, as we'll discuss, and it also has major relevance to a whole host of neurologic disorders. If you don't read the cartoon at the bottom, I will tell you that it is not something that is very well taught in medical school, and I hope you all have physicians who have done an Operation Bootstrap. What is sleep? It's a reversible behavioral state where we're not involved in the environment and we're unresponsive, but unlike coma, it's physiologic, it's recurrent, and it's reversible. In fact, it's not the absence of wakefulness, but it's really a very complex difference in physiological and behavioral processes. Like any other aspect of medicine, people who study sleep, and there are many of us, we use certain technology, and you just have to understand that these are the tools The blood tests, or the EKGs of sleep, include polysomnography, which just literally means multiple sleep analysis. It's also what most people call a sleep study. We also have several other tests as well. The polysomnography is the gold standard, and it can use with a variety of leads, can tell the different stages of sleep by using the brain waves, by checking the eye leads, and by checking the muscle. But it also is very important to test for breathing and apnea, the heart rate, and we have several other monitors all at the same time, and the whole thing is videotaped. The multiple sleep latency test, or MSLT, is a semi-quantitative test for sleepiness during the day. What happens is 4 or 5 times every 2 hours, people are given the opportunity to lie in a dark room in bed and instructed to try to fall asleep. Believe it or not, if you are a normal child, it's almost impossible to do. They get 20 minutes to fall asleep, and once they fall asleep, they're given 15 minutes to stay asleep. And we can also look at the various stages of sleep that are done. Norms are available now for children from school age and above, and as I said, it is something which surprisingly should not be able to be done, but unfortunately many children are actually sleep deprived and will fall asleep easily. However, what distinguishes them from narcolepsy is that they don't go into dream sleep within those 15 minutes. Actigraphy has a different time span. Actigraphy is a wristwatch that measures movement, and it correlates very well, not perfectly, but very well, to wake and sleep and various stages of sleep. And what makes this an advantage is that it can be worn for an indefinite period of time. Unlike a 1-night or 2-night sleep study, you can go on for weeks on end, and it's far more accurate than any parent or individual sleep diary. This is a very idealized version of what happens when any of us fall asleep. We don't go directly into dream sleep. We actually go through progressively deeper stages of non-dream or non-REM sleep, and then we come out gradually, and instead of waking up, we start to dream. And we repeat this cycle, as you can see, about every 90 minutes through the night. I'd like to divide the night in half, and as you can see, in the first half of the night, you have much more of the deep non-REM sleep, and this is restorative sleep. And this is also when we have certain problems, as we'll discuss shortly, where you can come out of non-REM sleep, the deep non-REM sleep, in the first or second cycle and be partly aroused, but still your mind is asleep. On the other hand, in the second half of the night, what you see are longer periods of dream, and as you can see at the very end, you have a terminal dream period, and dreams are like fog. They dissipate quite quickly, so we often remember a single dream and then we kind of lose it as we're awake. But if I woke you up with every time that you had dreaming, you would be able to record and report different visual content. What I just told you, I said was idealized, and it actually changes dramatically from the time we're born. A term infant sleeps up to 18 hours a day and goes through cycles every 3 or 4 hours between wakefulness and sleep. And remarkably, within the first month of life already, the periods of daytime wakefulness start to increase and the periods of nighttime sleep start to increase. By 6 months of age, we're down from 16 to 18 to 14 hours of sleep, and we're already, if you're lucky, beginning to get pretty much a decent night's sleep. Interestingly, beyond 6 months, we start to have more awakenings at night. It may be due to just normal development. It may be due to teething. It may be due to other behavioral factors like learned association with breastfeeding, but it does become a little more fragmented. Beyond the infant period of time, it continues to decline so that we're down to about 11 hours. And by the way, when I give you means, that doesn't mean that a child is abnormal if they have more or less requirement, but this is pretty much the average. And by the time a child is a toddler, they're down to 1 or 2 naps a day. What you need to know is that if they have cat naps or a very long afternoon, late afternoon nap after about 4 or 5, that can interfere with a solid night's sleep. Many children have given up their nap by age 3. It becomes unusual and something of concern if a child in kindergarten is still taking a nap. Sleep problems occur in at least 20 to 40% of children, but what I think is one of the most interesting facts is that as a sleep doctor, we can't find much difference between those children who are called good sleepers and those children who are called poor sleepers. The difference is that the good sleepers don't bother their parents, and the poor sleepers are either louder or their parents are more vigilant or having problems sleeping themselves. As we get into school age, we continue to get less and less sleep, but we're still getting 9 hours of sleep. 10 hours of sleep by 9 years of age. And it's the 2nd, 3rd, 4th graders who on average are the very best sleepers in the course of one's lifetime. That child in the prepubertal range are the ones who have no difficulty falling asleep. They stay asleep, they wake up without an alarm clock, and you put them down every 2 hours and they almost never fall asleep. Remember, they're given 20 minutes to fall asleep, and maybe the average is 19 minutes. So that means that maybe on 1 or 2 naps they actually can fall down under optimal conditions. That's not quite true in teenagers in America these days. Teenagers are getting 8 hours of sleep or less, if lucky. And what I find to be absolutely dramatic is in the year 1900, they were getting almost 10 hours of sleep. And I don't know about anybody else, but I don't believe evolution works quite that fast. And in fact, there has been an explosion not only in Starbucks cafes, but in the use of stimulants and caffeinated beverages of all sorts. we'll talk about that a little more as we talk about the pathology of adolescent sleep. What I would like to point out is that adolescents are not entirely at fault. When studied, they actually, given the opportunity to fall asleep, will not fall asleep as early and will tend to sleep later. And that's because they have melatonin, which is the natural hormone secreted on a daily basis that doesn't kick in until several hours later and doesn't stop for several hours later. So in fact, when we start our high schools at 7:30 in the morning and our elementary school at 8:30 in the morning, we're running counter to nature because the children are up and ready when they're in elementary school, and they really do want and need and are biologically prone to sleep in when they're in high school. What are some of the common sleep problems? Well, the first job of a child, of an infant, is to consolidate that sleep and wake, as I said, and get more sleep at night and more wakefulness during the day. And the other is to learn how to put oneself to sleep. And we call that settling. When you put a child down, how do they put themselves to sleep? There's no way to lecture a 6-month-old, or for that matter, a 16-year-old. They have to figure out what works for them. By the time they're toddlers, those difficulties settling and that difficulty, what happens when they wake up in the middle of the night, can lead to behavior disorders, but also the brain is developing and predisposes to night terrors and parasomnias, which we'll talk about momentarily. And we're starting to see more obstructive sleep apnea. If you can't read the Dennis the Menace, it says when it comes to napping, he's guilty of resisting arrest. So what are the behavior disorders that occur why kids can't fall asleep? The first and one of the more important reasons are sleep onset associations. If you fell asleep in your bed and woke up on the kitchen floor, it'd be hard to get yourself back to sleep. And what happens is that many parents are cradling their children or driving them around or walking them until they fall asleep and tiptoe them into the crib. And those are the kids who find it hard to fall asleep. They're going to be the ones who are going to find it hard to get back to sleep. The second is unstructured or inconsistent routines. These are working parents, and many of us have 2 working parents now, who when everybody's home and you'd like them to get to bed early so you can have some quality time. When somebody's working late, you want quality time with the child, and they don't get into a normal routine. And you can see some of the others at the end. I have down here medications which keep them awake, and there are some like stimulant medications. And then there are children who have neurologic disabilities who have difficulty because of their abnormal brain of consolidating sleep or staying asleep. And what I'd like to point out is that settling does continue to be a problem, and up to 10% of preschoolers are still having frequent problems falling and staying asleep. What can you do short of medication? Well, common sense is the first thing. And this is what we'll be coming back to in terms of sleep hygiene. Consistency with a regular bedtime and a regular routine, avoiding overly stimulating activity, when you have an older child who gets a lot of exercise, that exercise is wonderful, but if you do it too late following exercise, there's what's called a forbidden zone, and it's hard then to settle down and get to sleep. I need to point out that while those are the most common and the best ways to do it, you really need to think about the relatively rare but serious issues with medical conditions, and apnea and reflux and other seizures need to be considered. If you're going to eliminate those things and you would like to improve the sleep difficulties in falling and staying asleep, there are a host of people who have come up with ways in which to help a child to learn how to fall asleep. Many of you have heard of the Ferber technique of graduated extinction, of letting the child cry for 5 minutes and trying to reassure them, and then extending that time with every one that you walk away from the child until they finally learn that it's up to them to fall asleep. And often within a few days, a child who's having great difficulty can learn on their own to put themselves to sleep. That's not the only way to do it. There have been anti-Ferber techniques that think that that's abusive to children. I personally think it's fine, but sometimes parents will try other things, such as limiting the bedtime hours to the time that a child sleeps, keeping them up, and only giving them 8 hours in bed if that's all they slept in the previous nights. And that way they're so tired that they do fall asleep, and then you can gradually extend those hours. Medication is an absolute last resort, especially in young children. I was talking about toddlers, and I said that night terrors and sleepwalking and sleep talking are not uncommon. In fact, they occur in the majority of children on a rare occasion. They typically happen at 3 to 5 years of age. It almost always occurs in the first third of the night, and it's often increased if a child is overly excited or sleep deprived. I would hate to be a neurologist in Orlando where Disney World is, because I understand that that's a big problem down there. What happens if you haven't seen this, or the child is very difficult to arouse, the more you try to wake the child up, the more agitated they become. I've always considered it like a clip from that old movie, The Exorcist, but after a few minutes, the child just falls asleep or wakes fully up and has no remembrance of what happened then or the next day. We do have to think about seizures, but when it occurs like that, 1 hour after, 2 hours after, with agitation and back to sleep, that's not a typical time for seizures, and it's a very typical time for night terrors. Also, recurrent episodes of similar nature are seen in the majority of families, suggesting that there is a difference in the delayed neurological maturation of the brain at that time, but it is not considered pathologic. We recently at the hospital had a 15-year-old who for the first time started to have night terrors, and I was not at all surprised, unfortunately, when that child turned out to have a seizure, and it turned out to be, unfortunately, a brain tumor. So a 15-year-old does not start with night terrors, but a 3 to 5-year-old, that's by far the first thing you think of. If it's of a typical time and a typical age, one needs to relax and be reassured. There's an old wives' tale for some people that say you can't hurt yourself. Unfortunately, that's not true, so I would not recommend leaving roller skates on the top of the stairwell. There are treatments that are available. One of the things you could do is put a gate or turn the bedroom door to a half door, because you don't want to lock a child in and feel enclosed. Behavioral approaches are possible. There is an evidence-based approach that says that if a child always has these terrors or agitated arousals 3 to 4 hours after they fall asleep, you can wake them up at least 15 to 30 minutes before you expect them to have an event. If you do it too close, you can bring on the event and do that for 1 to 2 weeks, and you have a 50% chance of breaking the cycle and not needing to do anything more. There are medications related to diazepam or Valium, also like clonazepam, which are long-acting, but not so long-acting that they cause drowsiness or hangover effect the next day, and those can be effective. We talk about night terrors and sleepwalking and talking, but there actually are other kinds of problems that can occur. Head banging or body rocking, it's called now, nightmares, and even bedwetting is considered a parasomnia. What's important about bedwetting is that it resolves typically prior to elementary school, but at 6 years, in other words, kindergarten to first grade, 15% still have primary enuresis. And whether you treat it or not, 15% improve every year, so that by adolescence, 2%, and in surveys of Army recruits, 1% are still having problems. There are treatments. I don't have time to go into it, but everything from alarms to medications can be effective. What you really need is the child to buy in. So if they're not interested or they're not ready, then it's not worth doing. At Children's Hospital, there is even a clinic called the Dove Clinic, or Disorders Avoiding and Elimination, that take both a physical, physiologic, and a psychologic approach. And I would recommend that comprehensive approach for bedwetting. The other big problem of childhood is apnea. Now, apnea may occur actually in infancy, but it becomes more of a problem because during early childhood, our tonsils and our adenoids are growing, and unlike when I was a child, we tend not to remove it, so that we have this lymphoid tissue which is there to fight off infection, but in fact it can also block the airway. And when we talk about apnea, we're talking about absence of airflow, and there are two kinds that you can have. One is obstructive, when something like the tonsils or adenoids block it and you're trying to breathe, and the other is central, when the brain doesn't tell itself to breathe. So central apnea is either due to central nervous system dysfunction in older children or immaturity in premature babies. How do you know if your child has obstructive apnea? At night, you hear the same loud, noisy snoring and gasping respirations. that you typically talk about in large overweighted males, adults, but it does occur in children, and because of tonsils, because of upper respiratory infections, it can become a serious problem. Children have very restless sleep. A patient I saw yesterday in the office said not only does he have all that, but he wakes up as if he had been running a marathon with sweats, and often these children will have bedwetting because of the arousals that they have from the frequent awakenings and arousals that they get, up to many, many times per hour. But it's not only the night problem. It also has an impact on daytime functioning. Rarely in children, but more in older adults, they'll wake up with headaches or very dry mouth because of the mouth breathing. Children become overactive. I said overactive versus hyperactive because I don't believe that apnea typically causes ADHD, but it mimics ADHD with its overactivity and its inattentiveness and its learning challenges, its irritability and its lashing out. The children may show fatigue, but remember, think about when your children were 1 or 2 and they were overtired. You knew how tired they were, but they were just irritable and couldn't focus, and they looked like anything but sleep. The treatment of sleep apnea is often taking out the tonsils or the adenoids. I don't know if you can see it here, but these are the tonsillar pillars, if my arrow shows or not. And this is after they're out. You don't see the adenoids because they're hidden behind the uvula. It's not the only thing. Because we see so many children with neurologic issues or children who have craniofacial abnormalities, the tonsils are not the point of blockage. And if the whole airway is small or they're so hypotonic and you can't do anything about it, there are other treatments like nasal CPAP or continuous positive airway pressure. We are living in a society where obesity is becoming an increasing problem, and often weight loss in children or adults for that matter can make the difference between significant apnea and better health. In older children, we start seeing more difficulty falling asleep and staying asleep. We still see the same obstructive problems, and we start seeing more sleep schedule disorders as well as sleepiness during the day, and a new issue of periodic limb movements, which when I was in medical school was said not to occur in children, but we now know that's not true. The periodic limb movements are these brief, typically leg, but it can be other extremities that occur every 1/2 to 5 seconds in a repeated fashion. You may not even notice it if you're lying with the child because it's very subtle, but it's often just enough to keep them from staying asleep, and it knocks them out of light sleep. As you get to be older, and I assume I'm talking to mostly adults, you may hear about restless legs, which is that feeling of difficulty, of discomfort, of not finding the right position. It's relieved by moving around, and it seems to get worse during the day. This is a problem that in childhood, when it does occur, is often called growing pains. But most children don't complain about it for reasons we don't fully understand, and we rely on the more objective periodic limb movements. What makes us think about it is the difficulty falling or staying asleep, or the discomfort in fewer patients, and a family history is often positive. You can see here in more than 2/3. There are tests that we do, but not too many. The majority of children who are found to have this problem will have low iron or low ferritin, which is an iron-binding protein. There is treatment for this. Firstly, avoiding medicines that can make it worse if they're on it. And then if the ferritin is normal but low, we will treat with iron, often associated with vitamin C, to help with the absorption. And then for more serious cases, there are other medications that we can use. And this has become very popular to understand, because it is one of the treatable causes of insomnia, although it's certainly not the most common. By the time we see teenagers, we are really dealing with mostly difficulty falling asleep, at least at the right time, and difficulty staying awake when they ought to be. And there are various causes. Without a doubt, the most important cause is not giving one enough time in bed and not having good sleep hygiene. We mentioned it before, the sleep hygiene, but if you avoid falling asleep, if you're very irregular, if you're self-medicating, and most importantly, and this was shown by a study done by the National Sleep Foundation a few years ago, 3 or more electronic devices in the room of a child, almost by definition, means that they have inadequate sleep. And 3 or more devices, from a phone to a Wii to an iPad to whatever, is probably becoming de rigueur in most bedrooms these days. And as you're talking about teenagers, everything is compounded by the normal need to be their own persons. And so you say yes, they'll say no. Add to that what I've already told you about melatonin and the fact that they are naturally late sleepers and night owls, at least until they're in their mid-20s or 30, when it goes back to an earlier cycle. And in addition, we really do need to think about tobacco. We need to talk about alcohol, and we need to talk about other drugs of abuse. Those of you who say it doesn't occur aren't living in the world that I know as a pediatrician and as a neurologist. Once again, although not common, psychophysiologic insomnia and other sleep disorders are relatively unusual, but do need to be ruled out. It can be treated. It absolutely can be treated with sleep hygiene, the avoidance of caffeine, and excessive exercise. One thing I would like to point out, and in fact was pointed out in the show this morning, bright light in the computers that kids are sitting in front, that I'm sitting in front of right now, can delay melatonin. And melatonin is the natural hormone that predisposes to sleep. So I know it's counterintuitive, but keeping kids away from the computer late at night, keeping them away from sitting too close to the TV, which is less likely to cause the problem, sorry parents, is a problem. Medications really should be used for short-term only, and there are medications. There is melatonin, which is not a sleep hypnotic, but needs to be given 30 to 45 minutes before bedtime. And then there are these other medications from clonidine to zolpidem, which is Ambien, mirtazapine, which is Remeron, trazodone, and diphenhydramine, which I don't recommend Benadryl because there really is little evidence for its usefulness chronically, and there are side effects including paradoxical activation and increased seizures. There is delayed sleep phase syndrome, where it's difficult for a child to fall asleep at the time you want them and they need to fall asleep. It is not uncommon in children who are predisposed to being night owls as opposed to early morning larks. If given the opportunity, they'll sleep and sleep normally, but it doesn't work if they go to bed at 2 o'clock in the morning because school still starts at 7:30 in the morning. And what happens is they're miserable getting up, they hate getting up, and in fact they have secondary gain after a while because they like being up at night and they don't mind avoiding school. So that it needs to be treated. And again, melatonin can be effective. The problem with melatonin, by the way, is that over-the-counter melatonin is not FDA regulated, and so it's hard to know what you're actually giving. There are some other techniques like moving them around the clock, and then the important thing is whether you go forward or backwards to get them to the right time that you want them to fall asleep and to wake up, and keep them there. Those of you who have kids, you want to feel sorry for them and let them sleep in on weekends, but that only makes it that much harder to get up in the morning and to get back into the swing of things if they already have that problem. There's also something called light therapy, and I don't know if you can see it here, but very bright light in the morning will shut off your melatonin and reset your biologic clock. Once again, medication is only a last resort. I know I'm running a little bit over, so I'm going to race through this. Sleep and epilepsy, it's very important to understand that most children who have seizures while asleep, and some of them only have seizures while asleep. There are certain conditions that are very common that occur out of sleep, including Rolandic epilepsy, which, as bad as it sounds, is a benign condition and is outgrown and may not even need to be treated. And then all the rules of what a normal seizure looks like are thrown out the window with frontal lobe epilepsy, and I would only recommend that you talk to your pediatrician or neurologist if you have any question. I'm not going to go through this in the interest of time, but I will say that anything that you can do that improves sleep will improve seizure control, and these slides will be available as PDFs later, and I apologize for running through it. I would like to point out that if there is seizures in the child, apnea is more common and it is more important because almost a third of patients with epilepsy that is difficult to control will be determined to have sleep apnea, and if you treat the apnea, you actually get better seizure control. Part of all of the reason here is the bad brain, but part of it also is that many of the medicines that we use to treat seizures will cause weight gain or are sedating so that they don't wake up as often and as easily. I would like to point out that there are many genetic syndromes that we're identifying more and more that can have impact on sleep. Trisomy 21 or Down syndrome is very much associated with obstructive apnea because they tend to be overweight, they have large tongues, they have relatively small chins, and they have large tonsils. All of that leads to big problems. And then there are other disorders like Smith-Magenis syndrome, which is a disorder of a deletion on a chromosome, a very small deletion, but it leads to cognitive difficulties. And part of it is that they don't have normal melatonin, and so they just don't sleep, and they're incredibly irritable all day. Autism is perhaps more important in the group I'm talking to. What I'd like for you to know is that over 80% of kids with autistic spectrum have major sleep problems, and it's independent of their intellectual capacity. That said, most of the sleep disorders are behavioral. Most of them are behavioral and don't need to be treated with heavy-duty medicine. One does need to recognize that up to 40% of children with autism will have at least one seizure by the time they're 16, and nocturnal seizures and what's called Landau-Kleffner or epileptic autistic regression is a reality, but it's very unusual. ADHD has all sorts of relation to sleep in terms of settling down, and this is true even in those who are not treated with stimulants, before they're treated or with non-stimulants. The sleep tends to be restless, and they have difficulty in the morning. Primary sleep disorders don't usually produce ADD, but they may exacerbate the symptoms, like if there's an associated obstructive apnea or periodic limb movements or delayed sleep phase. All of those on their own can lead to trouble concentrating, and if you have pre-existing ADD, that's much worse. In addition, kids who have ADD, and remember 2/3 of kids with Tourette's have ADD, mood disorders, anxiety disorders, including OCD and migraine, can contribute to challenges in getting to sleep and staying asleep. If stimulants are used, the kids will need at least a half an hour less sleep at night. If you use medicines that last too long, that also reduces sleep. And paradoxically, if the medicine wears off too quickly and one gets what's called rebound hyperactivity, it's like getting that heavy-duty exercise before bed and the kids can't fall asleep. Finally, Tourette syndrome. I think you all know that many kids with Tourette's, even if they don't have major anxiety disorders at bedtime or OCD or ADD, will have sleep difficulties, but in fact, those are all compounding issues. I think you should know that we all ask whether or not you ever see tics during sleep, and the answer is always no. But in fact, when we do studies, we often will see tics in sleep. It's just not as prominent. Kids with Tourette syndrome do have an increased incidence of the parasomnias like night terrors and sleepwalking and talking. They also have a threefold increase in migraine, including nocturnal. And all these sleep abnormalities, of course, are increased, as I said, if they have the ADD or the anxiety, OCD issues. Here's an interesting paper that just came out, and in fact, I learned of it because it was distributed by the New Jersey Tourette Center, that 80% of a series that was unselected of Tourette clinic at a university in children had at least one of the following: insomnia, poor sleep efficiency, in other words, frequent arousals, short sleep, night terrors and parasomnias or nightmares, and 1 out of 5 of the kids in that clinic had 4 or more of the 5. And as if they had sleep problems, it was reduced to, it was associated with reduced quality of life for them and their families. And in this particular series, it was mostly anxiety, even more than ADD, that was associated with more problems. So in summary, when should you suspect a sleep disorder? If there's trouble falling asleep or staying asleep, if the kids are restless, if they're snoring or apnea, if they're not in bed long enough, if they're having ADD or aggression, and if they're sleepy during the day. Always remember, especially in kids with neurologic and developmental problems, to consider the underlying issues. Do they have epilepsy? Do they have apnea? Are they in pain? Kids with cerebral palsy have spasms and can't move as much. And then are we doing something with the medications, whether by keeping them awake or knocking them out with medicines that go into the central nervous system and make them sleepy during the day and break up their nocturnal sleep. Always consider sleep hygiene, a consistent bedtime, a regular routine in the morning. Staying up is the best way to get a good night's sleep, with the exception of appropriate naps that are short, never more than 45 minutes to an hour outside of the toddler period. We spoke about chronotherapy, or moving them around the clock. We spoke about light therapy, and then sleep agents, and those include the several that I've mentioned. I have some references here that I think are reasonable. There are many others, but these are a few good ones. And with that, finally, I will stop.
Well, thank you very much. A lot of great information. And we also have a lot of questions, so I'm going to kind of leap right into those right now, okay?
Sure.
We have had a number of questions related to sleep aids, melatonin, the iron you talked about. Someone asked a question about a mineral called GABA, G-A-B-A. I'd like to kind of lump those together a little bit, and could you just talk about the iron and the melatonin a little bit, and this GABA, if you're familiar with that? Is there a chance of, what are the concerns about the use of those? Would these be doctor recommended? Is there a fear of overdosing on any of those? So could you address that a little bit?
Sure. The whole concept of complementary alternative medications is a real challenge. The main reason is that the supplements are not controlled by the Food and Drug Authority. We often don't know exactly what's in the products, and we don't know, in fact, what else is in the product. And the purity is just not guaranteed. That said, there has never been, to my knowledge, any proven problem with store-bought melatonin.
Okay. At what age would you try that with your child?
There's not been a lot of research done in young children below 5 or 6 years of age, and I definitely try to avoid it in the smallest children. We don't know how to give it, and we don't know how much gets in. In older children, if melatonin does work, it often only works for 4 hours, and you sometimes trade sleep onset problems to midnight awakenings that are just as challenging. There is an extended release preparation that can help, and then there is a single melatonin agonist, meaning an FDA-approved drug called Rosarum, which is not recommended for children under the age of 16, but I have used it off-label in extreme circumstances, and it is being studied as we speak. I'm not recommending it routinely, but it is.
Is there any in terms of that mineral that was mentioned, GABA? I don't know if you're familiar with that or not.
Well, GABA, or GABA, is the major inhibitory neurotransmitter of our brain. The problem with GABA is that it's a very small molecule, and it is broken down in the stomach and in the bloodstream long before it gets into the brain. So it really, to the best of my knowledge, doesn't work. Many of the things that you're talking about are in the blogosphere and have testimonials, but they don't have much good science behind it.
Okay, thank you. Is there a genetic link regarding sleep problems such as walking and sleep apnea? And, you know, another question also about, you know, are adult night owls likely to have kids with poor sleeping patterns? So is there a genetic link with all of this?
You know, when you're talking about various behaviors that are common in the community, I think it shows that we do have biologic diversity, and it doesn't mean that any of it is abnormal. And the answer to both of your questions is yes. People who tend to be night owls tend to have kids who are night owls. I'm sorry, I didn't write down the first part of the question, but
the question was about sleepwalking and apnea as well.
Yes, and that also tends to reflect the pattern of brain development and the ability to be deeply asleep, more deeply asleep perhaps than others. And so, yes, but none of it is considered pathological, only if it disrupts the child and the family life, and it happens in an unsafe way, would we consider treating it.
Okay. Could you talk a little bit more about this whole role of electronics? You know, I understand not using stimulating
it's not so much the electronics that interferes with sleep. It's the fact that we are so technological and we're so wired that we're choosing to be involved with all these other things rather than sleep, and sleep is a default. I mean, you know, it's what you do when you're not having fun.
Yeah.
And there are more ways to have fun. I mean, in the old days, before we had electricity, people went to bed when it got dark, and they woke up when it got light.
Yeah.
And it was a lot easier to get a full night's sleep.
Yeah.
We are, you know, you want to go to the bank, you could go to your ATM machine at 3 o'clock in the morning, and you can go to the supermarket. So
in terms of
people are choosing.
Particularly about the part having to do with the light. So if the light from a computer screen, for example, is stimulating, would that same kind of light, is that the same thing as having a light beside the bed and you just read before you go to bed, or are they equated differently?
It's different. The amount of light intensity from a computer screen is significantly higher.
Okay, so that would apply to an e-reader then, or any of the, you know,
Yeah.
little, yeah, rather than a bedside lamp, the e-reader then would be more stimulating.
I haven't actually looked at the various e-readers, but it definitely is true that the light that the kids are doing, but it's not just the light, it's also the excitement of those computer games
Sure.
can rev up the brain and the tendency to fall asleep. Remember, falling asleep is two processes. You have to be tired and you have to allow yourself to fall asleep. If you don't have both, you're going to be in trouble, and many kids unfortunately are.
Yeah. Someone posed a question about the use of colored light to induce sleep. Do you know anything about that?
No, I'm afraid I don't. I think it may be similar to the use of white noise to
okay.
drown out. You know, constant noise is much less disturbing to consolidated sleep than noise that happens irregularly.
Mm-hmm.
So, but I really don't know. I'm sorry.
No, that's perfectly okay. Would you talk a little bit about night terrors that continue into adolescence and even into adulthood?
Sure. Night terrors that continue beyond early childhood tend not to be associated with major psychological problems, but night terrors often come back in adulthood under particular stressful conditions. One example is a child that I had been seeing for night terrors who had a father who had come back from serving in Iraq, and he had had night terrors when he was a child. They had totally disappeared, but as part of his post-Mideast syndrome, he resumed having the night terrors. So it can be part of PTSD, it could be part of anxiety disorders, and basically it disrupts, knocks you out of the wrong stage of sleep. When it continues, we often will study them. Usually we don't find anything, but every once in a while what wakes the kid up in the wrong stage of sleep, the older child, is apnea or irregular heart rhythm, or even, if not seizures, abnormal brain rhythms that are associated with awakenings and arousals. If it happens out of deep sleep, it can lead to parasomnia.
Okay, thank you. Would you comment more on the recent findings about apnea and behavior disorders?
Many years ago, when people spoke about apnea, they spoke about heart failure. That's because we didn't know that kids could have apnea, and it went on and on and on to the point that it affected the heart. Now, when people are so tuned into it, and ENT surgeons and pediatricians and sleep doctors think about it, whenever they see a child who's snoring or waking up at night, especially if they're obese, especially if they have enlarged tonsils, or if they have a large tongue, or they have a small chin, what we often see are the behavior issues that I mentioned, where they're irritable. I mean, all of us are irritable if we don't have a good night's sleep. All of us are less able to concentrate and or have a hard day socially if we're haven't had a decent night's sleep. And so that's more of what we see. we don't typically evaluate a kid for ADHD, and the first thing we think of is that it's all caused by sleep. But in fact, I think it's extremely important to take a sleep history in every child, especially those who are having neurobehavioral disorders of any sort, because take away 20% of their problem and they may be able to deal with it, the rest of it, much better.
Yeah, but isn't a sleep study typically a one-night event? I mean, isn't it kind of hard to measure that in that span of time?
Actually not. The hardest part is that there aren't enough sleep labs with enough nights to study a child. But in fact, it's now considered important enough that most ear, nose, and throat doctors won't take out the tonsils until they've documented how serious the apnea is, or if there is apnea, because they may not do the surgery even if they think it might be appropriate. No, a sleep study is an outpatient procedure. A sleep study is surprisingly easy on the kid and even on the parent, although if you saw all those wires around the eyes and the mouth and the nose on the chest, you would say, how could anybody ever sleep? But in fact, we almost never have a difficult time with the child, and there's much less night-to-night variability if it's something like apnea, because the upper airway relaxes the same way whenever they fall asleep, and the tonsils are blocking whenever they fall asleep. And so, sure, it might be a heck of a lot worse if they had a bad cold, but we usually don't have to wait for that. We just do the study when we can. Yeah. All right, we're coming to the end. I think we've got time for one more question, and this one has to do with what you talked about in terms of light and the fact that, you know, in the old days you went to sleep when it was dark and you woke up when it was light. There was a question about the whole daylight savings time and Eastern Standard Time and the difference that hour makes for some kids. Right. And I would think in this whole thing of settling down at night, that hour can make a huge difference. In fact, it certainly did with my kids when they were younger. Or I thought it did anyway. It may not be easy to tell, but in fact, if you look at large series, it is absolutely incredible. The rate of accidents goes up because of that. In the day that we go to daylight savings time, of missing that 1 hour of sleep, car accidents go up very statistically significantly. And that's the extreme example. But it's also true in children that they have a hard time. We all have a hard time with traveling across time zones. And I like to say that it typically takes 1 day for every hour of time zone, so that if you go to Europe and it's 5 hours ahead, it's going to take 5 days before you really fully accomplish. You can do it with, there are some tricks for traveling across time zones. 1 hour is rarely enough to cause a major problem in a child, and besides which, these longer and more beautiful days with the cherry blossoms are worth every missed minute of sleep. Huh? Okay. Right. On that note, then, I think we're going to wrap it up for this evening. Dr. Bruns, thank you so much. A lot of great information. We appreciate your time. Thank you, Marty, and I hope people found this of interest. Bye.
Thank you for joining our webinar on sleep and developmental disabilities, lessons for all children. There is an exit survey which we need everyone attending to fill out. If the discussion board is now open and available for the next 7 days on the NJCTS website. For any additional questions, that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, Managing Tourette Syndrome in the Classroom, presented by Susan Connors, is scheduled for April 11th, 2012. This ends tonight's webinar. Thank you, Dr. Brown, for your presentation, and thank you, everyone, for attending.